Hello, friends. Good morning. Today I'll be talking on this topic ventilating flail test. So I gave this talk in a W4C conference that happened in Jaipur on 16 September 2023. So it's a topic which focuses mainly on the management of flail chest. So before that, we need to understand what really happens in the flail chest. And I'm sure all the listeners who are hearing to this know that flail chest happens when there are multiple ribs that are broken and the chest wall is moving independent and non-synchronous with the breathing in inspiration expiration. So we need to know what happens during inspiration and what happens during expiration. So during inspiration, if you uh, just look at yourself, the chest has to expand. So once you breathe in, chest moves out. So when it moves out, what happens in the flail chest is the flail segment where the ribs are broken moves in. So it does the opposite. Where the chest is moving out, so the flail segment tends to move in. So there is a paradoxical breathing, what we say. And the opposite happens. So when you are exhaling, so the chest goes in, but the flail segment moves out. So the opposite happens. So if you diagrammatically keep this in mind or schematically, so you would know that opposite is happening during inspiration and expiration. So I'll show you just a video to show what happens. If you see here, so during inspiration and expiration, there is an opposite movement that is happening, and there is a paradoxical movement of the chest and the flail segment. And this is what typically you would see in a trauma patient. And again, to show in a schematic way, so when there are multiple ribs broken on any side and it is moving independently, non-synchronous with the inspiratory movements and expiratory movements, we call it as a flail chest. And again, diagrammatically to show, so during inspiration, when the chest moves out, the flail segment moves in and the diaphragm comes down. And during expiration, the opposite happens where your chest moves in and the flail segment tends to move out. So this is typically what happens in the flail segment. But there are certain caveats in the flail chest that one needs to bear in mind. So if someone in a polytrauma with a flail chest is intubated and mechanically ventilated, so the flail segment tends to be minimized, and we call this as internal pneumatic stabilization. So when you are ventilating someone with a flail chest, be it non-invasive ventilation or intubation mechanical ventilation, there is some amount of stabilization of the chest wall that happens due to positive pressure ventilation, which we call as external or internal pneumatic stabilization. So that's the terminology that is used. Just keep this in back of mind. And another caveat in flail chest is the risk of flail chest increases with increasing age. So as the age increases, the risk of having this flail sort of a component increases. And in the younger or the pediatric age group, flail segment is seldom seen. So the risk increases with age and it is low in children. So which is also important for us to bear in mind if there is an elderly patient who has a chest trauma, the risk of flail segment or the flail chest is lot more. And the pattern of injury which causes placement is typically a anterior sort of an injury to the sternum that happens in without a seat belt when there is a trauma to the front of the chest, and especially with the sternal injuries, the flail segment tends to ensue. Or the commonest one we see in polytrauma is a two-wheeler fall where they have fallen on the whole weight of the body is fallen on the chest. So where there is a crush injury with the impact which is borne on the chest, we see a flail segment. So any injury to the chest wall, which is of blunt injury sort of a nature, with a high impact injury, or the body weight causing significant injury on one side of the chest when they fall from a bike, is typically we see this flail chest. So the topic is we'll focus more on the treatment. The main goal of treatment when someone comes with a flail chest is multidimensional. It has three dimensions. The one important dimension is to ensure they are absolutely pain-free with multimodal analgesia. So now the concept is, we have spoken this in multiple talks. It's all about multimodal analgesia. We need to use different aspects of analgesia. Maybe we have to use paracetamol, little bit of opioid, and if renal functions are normal, maybe bit of NSAIDs. And most important in fail chest, consider using epidural because in our practice also, most flail chest, good pain relief can be attained, and some synchronicity with the breathing also could be established with good pain relief. And epidural comes very handy, or regional anesthesia or intercostal nerve blocks, one and so forth, could be thought of. But definitely, this multimodal analgesia is one of the important paradigm in the management of flail chest. And second important component is protecting the respiratory function, which means if they are hypoxemic, obviously you have to ensure there's adequate oxygenation, adequate sputum clearance, and adequate stabilization of the chest wall. And the third most important aspect is stabilization of chest wall. So you would see in the past, so stabilization of chest wall, people used to speak about surgical options. Now this is pretty much become obsolete. So there is no sort of a surgical option, and it is seldom considered in the flail chest. And most stabilization of the chest wall, when we speak today in flail chest, it is with positive pressure ventilation, either with NIV or with intubation and mechanical ventilation. And as intensivists, we'll see which one is better, whether NIV or intubation and mechanical ventilation is better. So when we talk about positive pressure ventilation, we call it as pneumatic stabilization. One is external pneumatic stabilization, which is through NIV. And when we say internal splint or internal pneumatic stabilization, it is with intubation and mechanical ventilation. So whatever evidence is available in flail chest, it is very clearly shown that the use of NIV in stabilizing the chest wall has shown to reduce the hospital and ICU length of stay, and has shown to reduce the duration of mechanical ventilation, shown to improve oxygenation, and it has most importantly shown reduction in the rate of patients going on to need intubation and ventilation. I'll show you a few studies, and most of these studies obviously cannot do randomized controlled trials comparing NIV versus intubation, but there are good retrospective and observational studies which allude to this aspect. So this is an important sort of a message at the end of the talk, that NIV is something that has more benefit rather than jumping on to intubate. Obviously, if they are failing, then you have to intubate. So NIV has to be the first choice in these patients. And obviously, when we put patients on NIV with flail chest, seldom the patients with flail chest will have other injuries. They can have TBI, traumatic brain injury, or they could have had abdominal. So it would be a polytrauma situation. So when someone is operated, obviously you wouldn't give a trial of NIV, you would straight away intubate. But if it is a pure chest injury, flail chest, patient is conscious, hemodynamically stable. So once you put on NIV, you have to see how they're responding to the NIV, whether their tachycardia is settling, hypoxemia is improving, and hemodynamics are improving, and respiratory rate is getting better, and accessory muscles of breathing are getting better, improved mental status, and whether there is any coordinated muscle movement, and whether patient is getting more comfortable. So all these are something that you need to watch for to look at the success of NIV. And obviously, you would do arterial blood gases in some frequency, either fourth hourly or sixth hourly, to see if gases are improving, if there's no carbon dioxide retention, so on and so forth. But if there is deterioration on NIV with a worsening or non-improving ABG, or patient is not tolerating, because very often it is normally generally the pain severe. If the analgesia is not adequately addressed, that is when the intolerance to NIV tends to increase. So if there is a good analgesia with a multimodal approach, with all the other components of analgesic modalities that you have adopted within epidural, their ability to tolerate NIV also will be much, much better. But if there's intolerance or failure to coordinate with machine, so these are some of the reasons you think that NIV has failed, and then you may have to consider intubation. And if there is gross hemodynamic instability, or if there is some sort of an arrhythmia setting in, that's when you would say that NIV has failed, then you would go on to intubate. But having said that, the evidence tends to give a signal towards giving a good trial of NIV, and NIV is, if it succeeds, I think it tends to improve good outcomes in flail chest. And you would obviously withdraw NIV. You would wean the NIV if tachypnea is settling, heart rate is settling, and pH is improving, and saturations are improving. So these are something which is very intuitive to most of the intensive care trainees who are listening to this. So now we'll move to, if they failed NIV and obviously NIV trial has not worked, then obviously you have to intubate and mechanically ventilate. And the reason why they fail NIV and they go on to needing intubation is when there is a severe sort of a flail chest, there is underlying lung contusions. And these lung contusions obviously has got perpetuated, and that leads to ARDS. So that ARDS is not uncommon in a flail chest. So there is a lot of inflammatory exudates that get filled into the alveoli and they develop ARDS. And this is a situation that where you may have to recognize that NIV has failed and one needs to intubate and mechanically ventilate. When someone is ventilated, the strategy is to minimize airway pressure and permissive hypercapnia could be kept in mind. And your efforts is to reduce the risk of patient developing BILI and reduce the risk of hyperperfusion of these alveoli and reduce the risk of ongoing or perpetuating ARDS. So the TNETs of mechanical ventilation in failed chest is pretty much similar or same as the strategy that you would adopt in ARDS patients. So it's the principles of protective lung ventilation that you would adopt for patients with flail chest as well. So it's like in ARDS, you would measure the predicted body weight with the height, and you start with tidal volume 8 ml per kg per body weight, and over 3 hours you reduce the tidal volume to 7 ml per kg, and then you progressively tend to decrease the tidal volume, and you will check obviously this titration of the tidal volume is in keeping in mind the plateau pressure. So you need to keep taking the plateau pressure at least 4 to 6 hourly and aim to keep the plateau pressure less than 30 centimeters of water. If plateau pressure is high, obviously you would reduce the tidal volume further, and and efforts are made not to keep the plateau pressure more than 30. And if it is still more than 30, then obviously you would keep reducing the tidal volume by 1 ml per kg per body weight. And P plat ideally should be kept less than 28 centimeter of water. And obviously the principles of arts-net ventilation is that you would maintain, you would accept PaO2 of 55 to 80 and maintain the saturation at 88 to 95%. So these are all the same components of ARDS sort of a ventilation that one needs to utilize when you're dealing with flail chest. And for this, you have to obviously adjust the PEEP and FiO2 to maintain the saturation at 88 to 90%. So now the question is, in flail chest, would you use high PEEP like high PEEP or optimal PEEP or low PEEP as in ARDS? So what is the understanding of high PEEP? So because there is a flail chest and there is atelectative alveoli and there is collapsed alveoli, so PEEP of 5 you give, so the alveoli would remain collapsed like this. But obviously, you optimize the PEEP, then the alveoli tend to open up and there is better recruitment. And PEEP has a tremendous influence on clinical outcome because in ARDS, the lungs are very heterogeneous and the ventilation is happening with a lot of heterogeneity. So we need to determine whether we are dealing with a recruitable alveoli or non-recruitable alveoli. If it is recruitable alveoli, then high PEEP is shown to be beneficial. If it is non-recruitable alveoli, then high PEEP can lead to overdistension and it can lead to barotrauma. It is detrimental. So how do we determine what is the right PEEP that we have to give in these patients to uh, prevent or mitigate the perpetuation of the ARDS? For this, we have this driving pressure. I'm sure most of the listeners would be adopting the concept of driving pressure. So driving pressure for us is a good prognostic variable which will tell us whether it's a recruitable lung or a non-recruitable lung. So if you look at this, if P flat is rising, so obviously what you would do is, and if PEEP remains the same, so you're not increase the PEEP. So which means the driving pressure continues to rise because P flat, driving pressure is P flat minus PEEP. So P flat is rising, you're not optimized PEEP, then mortality will increase because your driving pressure increases. But if your P flat is going up and you're optimizing the PEEP, then what happens is your driving pressure remains the same, so the mortality is the same, and at least you have here tried to optimize the peak. But what we really expect in a situation and in patients who do well is where P flat is the same. So P flat is not increasing, but PEEP you have optimized. So we need to be in this situation where your P flat is not going up and PEEP you have optimized, then your driving pressure comes down and your mortality comes down. So this is what we have understood with the driving pressure as to how we should utilize driving pressure to optimize optimal PEEP. Because you keep the same PEEP, then the P flat is high, then your driving pressure is high, mortality would increase. So This is where the concept of PEEP optimization comes, and if it is a recruitable alveoli, it tells you that you increase the PEEP, your P-plat also comes down, and your driving pressure comes down, and mortality could be brought down. So this is our conceptual understanding of high PEEP where it is beneficial. Suppose if P-plat is not coming down, obviously you have optimized PEEP, then we know that the driving pressure is the same, and at least we know these are the patients who may not have a great outcome because they have more of non-recruitable alveoli. So in extremes of situations, double human ET tubes is something that could be considered for flail chest, and this happens especially when because flail chest is not like typical ARDS because there may be one lung which is more significantly affected where the flail component is there, and the other lung is reasonably okay. So in that situation, you may need to have a differential volume between the normal and the abnormal lung. So obviously, if this is a normal lung, the tidal volume and PEEP that we give here is very different to the lungs, which is very severely affected. If suppose this is a flail chest with a severe sort of a crush injury with ARDS, so obviously we need to give much lower tidal volume and PEEP as compared to the normal. So this is where your double lumen tube will possibly help in giving differential tidal volume and PEEP to two different lungs by giving lower tidal volume and PEEP optimization, and this may overcome the shunt in the more severely injured lung. But if we give the same sort of a tidal volume to this, it may lead to dynamic hyperventilation in the normal lung. So this is our understanding as to what happens, in more severely affected lung as compared to the normal lung, especially in the flail case. So double human ET tube is used as an extremes of situations where one lung is more severely affected than the other, where we cannot deliver the same tidal volume and PEEP to both lungs. So that is our understanding. So now just moving into the studies that have shown us as to which modality is better, whether we should intubate early or wait and put them and give them a trial of NIV. So this was a biggest study which came from Japan, from Tanaka et al. It came in 2001, where they've spoken about pneumatic stabilization of flail chest, 11-year study. So this study was done in 132 patients. So as you see, the group A patients were intubated and mechanically ventilated, and group B were patients who were on NIV. And as you see, they have given different modalities: epidural analgesia, this is respiratory physical therapy, CPAP and PEEP, and endotracheal intubation, and prayer support, intermittent mechanical ventilation. So they found in patients, 59 patients who received CPAP, there was a lower risk of lung complications and lower risk of them needing intubation and mechanical ventilation. And based on this study, the sort of authors deciphered that the NIV trial has to be given, and they came out with this sort of an algorithm. So any patient with flail chest should have epidural analgesia, and analgesia has to be fully sort of optimized. After this, they need to be given a trial of NIV with PEEP, and if they only fail that, then they need to go for endotracheal intubation. And when they get intubated, they need to be on controlled mechanical ventilation to rest the lungs, and later on wean them to intermittent mandatory ventilation and spontaneously breathing. And NIV is something that needs to be trialed out after optimizing analgesia. And the way NIV helps is we have clearly understood that in patients with a flail chest and with a impending ARDS, the plateau pressures are more at the site of injury, and there is maldistribution of the lung, and there is increased diaphragmatic contractions. And all this could be mitigated with the use of forced pressure ventilation because your transpulmonary pressure can be brought down, there can be more homogeneous distribution of gases, and there is reduced diaphragmatic contractility. So these are some of the benefits that NIV confers in patients with flail chest with impending ARDS. So this is another study that came from Turkey. Again, so all these are retrospective studies. As you see, they had a endotracheal tube ET group and the CPAP group. And if you see, the complications were significantly more in patients who were intubated and mechanically ventilated because the risk of pneumonia was 47.6% in intubated patients versus 9.1%. And the risk of acute kidney injury or renal failure was more in intubated patients as compared to CPAP. And even if you look at multi-organ failure and ARDS was more in intubated and mechanically. So again, the conclusions they made was NIV and the usage of CPAP with patient-controlled analgesia showed reduction in mortality and reduction in the risk of infection, but the oxygenation and length of stay, hospital and ICU were similar. So we had a Japanese study which also alluded to this that NIV was found to be better, and even this Turkish study also showed. Then there is another Indian study which was published in the Saudi Journal of Anesthesia in 2019. Here again, they had it's a small study, 15 patients with flail chest who were intubated and mechanically ventilated, compared to 15 patients who had NIV. If you see the complications were much higher, 66.7% in patients who were intubated versus 6.7% who were on NIV. And mortality also was significantly higher in patients who were intubated as compared to NIV. And even in this particular Indian study, there was an emphasis and a focus on a multimodal approach with regards to analgesia. As I said, it has to be a combination of paracetamol and NSAIDs if kidney functions are normal, opioids, and epidural. So having these components will go a long way in optimizing analgesia. So the take-home message at the end of Flail test. So I think one important message or a signal that tends to resonate from whatever literature search you do is a significant beneficial role of NIV in this Flail test. Don't jump and intubate is the strong message that comes. So the take-home message is we need to understand in flail chest, there is a paradoxical movement of the chest. So during inspiration, where the chest moves out, the flail segment moves in. During expiration, where the chest moves in, the flail segment moves out. So this we need to bear in mind as to what really happens in flail chest. The treatment principle has to be multimodal and it involves three important dimensions. One important dimension which I have to emphasize is good, adequate analgesia. We cannot treat flail chest without addressing analgesia, and analgesia has to be multimodal. Use paracetamol, use NSAIDs, use opioid, and epidural or regional. All these four components have to be used to address adequate analgesia and do good ICU care to take care of your lung functions, good tracheal toileting, and good sort of a infection control measures to prevent secondary infections, improve hypoxemia with oxygen supplementary devices. And if there is a flail chest, one needs to stabilize chest walls with either external pneumatic. So the first choice would be non-invasive ventilation. Surgery is obsolete. First choice is non-invasive. If they fail non-invasive only, despite doing adequate analgesia supporting lung function, then you need to resort to intubation and mechanical ventilation. And once they're intubated, they need to be on a controlled mechanical ventilation, like in any severe ARDS. And as the situation improves, then you may have to wean them to allow them to start breathing spontaneously and wean them off. So that is the summary of the management of flail chest. So I request all the listeners to submit their valuable work to our journal, Journal of Acute Care, which is a every 3 months we come out with an issue. So you can submit your valuable work. Visit my website www.drpradeepramkar.com to rehear to this lecture. So thank you one and all.